Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy!
Welcome to another episode of The Fellow on Call, the Hem/Onc podcast. We're coming at you from Rouleau University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we're shifting our attention to second-line agents for patients with ITP. Those patients that, despite first-line therapy, they got that steroids, sometimes that IVIg, and unfortunately, the platelets just don't stick.
Unfortunately, it does happen pretty commonly, so glad that we're getting into this important topic to cover.
Yeah, really excited to get into this. These are very practical things that you need to know. Stay tuned for our next episode, where we're just going to go through cases. So really excited to finish out the series with these last two episodes.
So without further ado, guys, let's roll that show. So I think that it's really important that we start today's episode acknowledging my big feat for today. Guys, I ran my first 5K this morning. Our listeners can't see it, but I'm literally recording while wearing my medal. I just want you to look at this, guys.
Ronak's got issues. I just have to say this. Who does this? I'll just throw that out. Who keeps on wearing it?
I think it's beautiful.
We've all done 5Ks. Who keeps on wearing it?
I feel like I've reached peak millennial energy in my life at this point.
This is Gen Z, Ronak. This is Gen Z.
I'm just very happy with the way that the run went and my time and all of that stuff. So I'm just allowing you guys to revel in the magic of the hot chocolate run in Philadelphia with me. So thanks for amusing me this morning. Guys, last time we were talking all about ITP and we talked about how we approach these patients in the first line setting. Today we move on to that unfortunate situation, which frankly happens quite frequently, where patients develop relapse of their disease pretty quickly and sometimes even down the line. But nonetheless, what do we do in these situations? If I may, I'm going to remind you of the case that we were talking about last time, and then we'll set the stage for where we go from here, okay? So we had a 23-year-old female with no significant past medical history that had come to the ER with several days of spontaneous bruising on her arms and legs, and a new rash on her lower extremities. She had also endorsed some epistaxis and some gum bleeding on her review of systems. No recent infections, no new medications, no family history of bleeding disorders. And ultimately, when we had gotten a CBC on her, she had an isolated thrombocytopenia with a platelet count of 12. And despite the workup that we talked about last time, everything was consistent with what looked like ITP. And because her platelets were very, very low, we had treated her with steroids. And we also talked about in patients with very, very low platelets that we typically define as a platelet count less than 10, we can also talk about the role of IVIg in those patients. So, in this case, our patient, let's say that she ended up getting Dex times 4 days. She got IVIg times 2 days. She's discharged on hospital day 5, at which time her platelets were 45. Remember, per ASH guidelines, we want them to be at least double from baseline and greater than 20. And so she's at 45, no new bleeding. She's doing really, really well. We do recommend getting weekly CBCs at least on her. And the following week, you notice that her platelet count was 80. And then the week after that, it comes back at 28. You give her a call. She's got no new symptoms. So now what do we do?
Yeah, this is unfortunately something we do see pretty commonly. It's a little complicated because we know that she responds to steroids. She had a great response at first. It just wasn't sustained. In this situation, I think there are a few different options we can consider. I've often considered using an alternative steroid or basically a longer exposure to steroids. We know, as we mentioned in the last episode, that dexamethasone is sort of standard of care. But for folks who need a prolonged exposure to steroids, something like 1 mg per kg of prednisone can provide that sort of sustained exposure. And so if the drop was precipitous, you can kind of get weekly labs while somebody is on that extended duration of prednisone and sort of taper based on the response. But remember that by ASH guidelines, we really want to ensure that steroids are not continued for more than 6 weeks. And also, if you're exposing someone to steroids for a longer period of time, you need to be thoughtful about introducing GI prophylaxis, PJP prophylaxis. And these are the sort of things that you're going to need to think about with somebody on steroids for more than just that little burst.
So Dan, you mentioned that, okay, we tried pulse dose dexamethasone. We had a randomized study looking at pulse dose dex versus 1 mg per kg of pred with a slow taper and found that really it seems like the outcomes are similar long-term, but that pulse dose dex has less side effects due to less steroid exposures. But now we have this patient, tried the pulse dose dex, didn't work. when are you going to start tapering those steroids when you start that 1 mg per kg of prednisone?
So I'm going to let Dan have his chance to also speak, but I couldn't help myself. So I think the big thing here for our listeners is that there's going to be a lot of differences depending on which institution you practice at, what the practice patterns are. I wanted to share sort of what we typically do in my clinic. Typically, we recommend tapering every 3 to 5 days on those steroids. Sometimes if patients are having a harder time maintaining platelet counts, we may sort of do that over the course of a week. But the reality is that we're really trying to get our patients off of steroids in about that 6-week timeline. And that also, remember, that means that we have to check CBCs on our patients at least once a week. And we'll talk about this more in a second, but let's just say as you're tapering those steroids, patients' platelets continue to not respond. They're sort of fluctuating up and down, trending downwards. That should start sending off your spidey senses that maybe the answer isn't just in steroids. They may, in fact, need something else that needs to be started. We'll get to this in a second, but maybe this is your chance to start introducing that second agent while the steroids are being tapered down and as that other medication is ramping up. And again, we'll get into those nuances in just a moment. Dan, what is your practice pattern?
Generally, I am a little bit more aggressive with introducing those next line therapies. Unless somebody had a really sustained response to steroids the first time, so, they're not coming back with relapse until a few months in, then I might give them a chance with steroids alone again, probably just with another Dex pulse. But I am typically incorporating something like rituximab or a topomimetic agent or TPO receptor agonist at that first early relapse. And in that situation, I'm using prednisone as sort of a supportive measure while I wait for those second-line therapies to kick in. We'll talk about those second-line therapies in a little bit more detail in a second. But, as long as somebody hasn't been on that high-dose steroid for more than a few weeks, I taper really rapidly once the effect of those second-line agents has started to kick in. Because you wouldn't expect adrenal suppression unless somebody's been on that high dose of steroids for greater than 3 weeks. But if somebody has needed steroid support for longer than 3 weeks at a dose of greater than 20 milligrams of prednisone equivalent or higher, that you need to taper pretty slowly once you get down towards the physiologic range. So that's kind of how I manage it.
So I like this. We got two different approaches. One approach is, hey, let's use the steroids because at the end of the day, this is a long-term haul for this patient, and we want to really minimize their exposure to therapies that probably ultimately we're going to have to give them later, right? The patients who do not respond to steroids immediately, that dexamethasone, and have quick relapse of their ITP. One, you're looking for an alternative cause potentially, which we'll talk about. But two, you're probably thinking that patient's going to have more likely a chronic ITP type picture, needing future treatments down the line. So we have one approach, Roenick's approach, which is say, hey, try that mg per kg of prednisone and don't rely on keeping that on for like a month. I mean, taper that every 3 to 5 days because if steroids are going to work, they're going to work. And if they're not, they're not. And then you have the approach from Dan the Man Houserath here who says, hey, I don't care. Let's just go ahead and give that second-line agent with a rituximab-based therapy or one of these topomimetics. So before we get into those, I'm going to back up with a historical explanation of what we did in ITP before we had these fancy agents that these guys are going to talk about. So back in the day, it was splenectomy, remove the spleen. The idea was that these platelets were being cleared by the spleen, whether it was antibody-mediated mechanism. For whatever reason, it was the spleen that was the problem. And splenectomy actually works. And when you look at it, maybe about 60% of patients in systematic reviews continued to see their ITP in long-term remissions. And these were heavily pretreated patients, some patients who had got rituximab before, multiple courses of steroids prior to that. And so it works. 60% long-term remission rates. That sounds great, right? The problem is the risks associated with the splenectomy. Short-term risks, we have operative complications. These patients are going to surgery with no platelets. There are higher rates of VTE, both early and late, within 90 days and after 90 days of surgery, that these patients are at high risk for thrombosis. We're talking about potentially 2 to 4 times the risk of thrombosis. And that really is something to think about, though this was in an era prior to our modern VTE prophylactic strategies. It's still important to keep in mind. And then you have the long-term infection risks. You don't have a spleen. You have encapsulated organisms. There are vascular complications that are actually seen, though it's unclear what to make of that, right? Because these are from older studies that these patients are having more arterial events and things like that, but still it's something to keep in mind. And the truth is now in 2026, we have so many good agents. We're not just reaching for that splenectomy, particularly when you have an older, more frail patient, you really think about that, or even a young patient who's now going to live the rest of their life without a spleen. So in the modern times, what do you guys think? Where do we go from here for our patients? You heard about this patient who were, let's say we did the Roanoke approach. We tried some prednisone, 1 mg per kg. They responded, started tapering it at 5 days, then another 5 days, then another 5 days, and boom, the platelets are now back down to 20. What are y'all going to do?
I think that this is certainly a tough situation. I mean, certainly I think the way to answer this is that you got to do the acute thing and then you have to take care of the more chronic sort of management. So, in that situation, if they started dropping acutely, that might be your indication to sort of backtrack on that steroid taper, maybe bringing them back to the dose that they were at least having some response at, which may even just mean an increase of like 5 or 10 milligrams. You don't necessarily have to start at the very beginning. But as Dan and I both mentioned, this is the time that we start thinking about those other agents. So this includes medications like thrombopoietin receptor agonists, rituximab, which we've talked about briefly. And these really are some of the agents that we're reaching for. There are some newer agents too that we'll get to in a second. But if you ask most people, I do this all the time, TPOs and Rituxan are tried and true for a really long time. So those are often the ones that we're reaching to next.
And among these next line options, my personal preference is for rituximab. It's always a discussion with the patient whether they prefer a sort of limited duration therapy, a few infusions, or an ongoing therapy that's all oral. In the case of a couple of the TPO receptor agonists, there is also an IV option that we'll talk about. But I usually counsel folks that, if we can get away with giving you 4 infusions of rituximab and kind of knock this thing out for at least 6 to 12 months, then that's usually the option that I offer first. We've talked about rituximab several times before. It's an anti-CD20 monoclonal antibody that depletes B cells, and they're generally thought to be responsible for the majority of cases of ITP. Remember, because of the long half-life of those antibodies that are already in circulation that those B cells have produced, it takes a while for rituximab to have its effect because you can kill those B cells and stop the production of new antibodies, but those antibodies that were there are still in circulation. So it takes a good 2-3 doses before you start to see the therapeutic effect of rituximab. And technically, Rituxan is not FDA approved for ITP, but it has been in use in clinical practice for over 20 years. So it's a well-established line of therapy. We estimate that about 60% of patients will respond initially, and about 40% of patients continue to have a durable response at 6 to 12 months. The good thing is that if patients do start to show signs of relapse around that point, you can reintroduce rituximab, do another course, and it may still be effective. But unfortunately, the duration of response is likely to be shorter than it was for the initial. You have to remember that rituximab can reactivate hepatitis B. And so part of my practice, whenever I'm first managing an ITP patient, before they get any treatment, especially IVIg, I do their hepatitis B panel. You don't want to confound the results of that serology panel with antibodies introduced from the IVIg. That can lead to false positives. So anyway, you have to get their hep B status before you start the rituximab. If they are hep B core antibody positive, you have to give some antiviral protection with entecavir. After that, I generally counsel patients that they may have a blunted response to vaccines for several months after rituximab and are generally just a little bit less immune competent than somebody who hasn't been exposed to rituximab. But by and large, other than infusion reactions like we've talked about in previous episodes, it's a pretty well-tolerated therapy that can give people a sustained remission from ITP.
I think this is really interesting. So Dan talked about rituximab, the data behind rituximab. Remember, we got 60% of responders, maybe 40% maintain that response at 6 to 12 months, once a week, 4 doses, and done. So that's the advantage of that. But it does come with its own things. You're getting an infusion, right? The other thing is you're getting some amount of immune suppression. That might be a little bit more cost-effective than some of these thrombopoietin mimetics. So Ronak, can you walk us through some of these TPO mimetics? We have 3 that we really think about here in the United States. So can you walk us through what these products are and a little bit about the data behind them?
And I think there was a big shift in the sort of classical hematology world, particularly during COVID, when getting to an infusion center was problematic. And even in many parts of the country where patients can't get to clinic once a week, even for 4 weeks, this continues to be an important point of discussion. So this is where I think the TPORAs really shine. I will say the other thing, and I'll talk about the nuances in a second, the response time to Rituxan is anywhere from 1 to 8 weeks. As Dan said, it can take a little bit of time to work. In contrast to this, TPO-RAs are kind of on the order of 1 to 2 weeks sometimes, depending on dose modifications needed. So if they're going to work pretty fast. There's a whole slew of options. There are no head-to-head comparisons. They're all felt to be equally effective with an overall response of about 75%, and durable responses, which is defined as a platelet count more than 50, is somewhere in the neighborhood of 65%. So the difference here, though, is that these medications need to continue to be taken sort of indefinitely in order for them to be effective. As I mentioned, there are a few different routes of administration that are available. There's romiplastim or Nplate, which is weekly sub-Q injection. There's L-Trombopag or Promacta, which is a daily oral tablet. And then there's Avatrombopag or Doptelet, which is also a daily oral tablet. Some things to think about. So L-Trombopag has a lot of food interactions, especially with calcium-rich foods, and can also cause LFT changes. And the benefit of Avatrombopag, in contrast, though, is that it doesn't have these same interactions. So again, something you want to keep in mind if you're trying to select between these agents for your patient. There was concern that TPO-RAs can increase the risk of marrow fibrosis, but this has never been substantiated, and it's something that we mention but don't really think about too much in this current day and age. There's also an increased risk of venous and arterial thrombotic events in the extension studies, and we'll have a link to that in our show notes. So again, just something you want to counsel your patients on, but it is a rarity. If patients are not responding to one agent, there is data to suggest that if you switch to another one, they can still have a response rate of 50 to 80%. So just because one doesn't work, it is worth trying a different agent, especially if they're open to trying a different agent. And then, as I mentioned, therapy is typically indefinite. The effects can be short-lived if the therapy is discontinued. However, there are some reports that estimate that roughly 10 to 30% of patients may be able to discontinue therapy without reducing any response. How we stratify who those patients are and who those responders are going to be, we don't really have a good way of doing that just yet. So truthfully, at least initially, it really boils down to preference. Like, is your patient okay with an injection versus something oral? And then, of course, because of where we practice, availability and cost is also something to consider.
I do want to mention one thing that we really aren't doing as much anymore, and that's the use of azathioprine. This was considered a steroid-sparing agent that we could try using in ITP in sort of previous iterations of our treatment algorithm, but the latest ASH guidelines conclude that azathioprine has a less favorable benefit to harm ratio compared to these other therapies. And so we're really not recommending going that route anymore. We'll talk about some of the alternative things to do if patients are refractory to these second-line therapies, but just remember that azathioprine, not really part of the treatment algorithm anymore.
I think that's great. And I want to recap something that Ronak said about these TPO mimetic agents. We don't know who can stop. Once you start the train, can you stop the train? And obviously, you can try it in some patients who have responded for maybe 1-2 years, but many of these patients say, hey, look, I had really low platelets, so I want to take that risk again, and we have no way to counsel them. We know that maybe 1 in 3 patients can come off therapy. That's something we really need to figure out. Who is that patient that can potentially come off therapy when they're on these drugs? When we talk about that VTE risk, it's about 6% in those studies. And I want to highlight that patients with ITP and chronic ITP are at high risk for thromboembolism. And that sounds really paradoxical and odd. And in our next episode, we'll talk about cases of ITP patients who do have a thrombosis, because it's something that you will encounter in practice. It's not unheard of for that to happen. And when you think about these ITP patients, they also get fatigue and some other systemic complaints that you wouldn't really think about for just a low platelet problem. So all of these, I think, are important. Lastly, I'll say, so remember, we've got this romiplastim, this weekly sub-Q injection. Currently, that's what's preferred for chemotherapy-related thrombocytopenia to get somebody through their chemotherapy cycles. There was a recent publication of a study looking at romiplastim in this setting that we'll link to our show notes. So that's another thing you can use. It's all about patient choice.
Vivek, we talked about TPO-RAs, we talked about Rituxan, obviously we talked about steroids, we talked about splenectomy. What are your thoughts on fostamatinib and rilzabrutinib, some of the newer kids on the block? You could pick whichever one you want to talk about first, and then maybe Dan can take over the other one.
So I'll first talk about fostamatinib. This is a twice-daily pill that is a spleen tyrosine kinase inhibitor or a SYK inhibitor. This SYK or SYK protein plays an important role in macrophage activation and subsequent phagocytosis of antibody-coated platelets, and the drug was approved after 2 phase 3 randomized studies comparing the drug to a placebo. Patients enrolled in these studies had ITP for at least 3 months and had platelet counts less than 30. Patients had to have had a prior line of therapy, including things like IVIg and steroids in most patients, and about half the patients had exposure to a TPO-mimetic agent, so very heavily pretreated patients, and about a third of them had undergone splenectomy or had received rituximab. Patients were assessed for response and continued therapy for at least 24 weeks, and the overall response rate was about 4 in 10 patients, 40% in the treatment arm, and only 14% of patients had a response in the placebo arm. And the percentage of patients who had a sustained response, so now we're looking at how many of these patients had sustained response, it was about 18% of patients. So 1 in 5 patients with fostamatinib will have a sustained response versus virtually no patients in the placebo arm. When you think about starting fostamatinib, some adverse events associated with the drug, most commonly we think about diarrhea, potentially some hypertension. So it's important that these patients get weekly blood pressure monitoring at home, that they monitor their blood pressure. And neutropenia is another thing that we can see. The average time to onset for platelet count response is about 1 to 2 weeks. So it's very similar to those TPO-mimetics. So you shouldn't be waiting 6-7 months to see a platelet response here. We should be seeing this within a few weeks.
Yeah, and I could talk about rilzabrutinib. This is one I'm pretty excited about. It's the newest drug in our ITP treatment arsenal as of time of recording. It was approved based on the LUNA-3 study, published just last year in 2025. It was a randomized placebo-controlled phase 3 trial comparing rilzabrutinib and placebo. So rilzabrutinib is a twice-daily oral pill. And as its name would suggest, it is a BTK inhibitor. And for those of you who are remembering back to our CLL series, you may be thinking, BTK inhibitors have an antiplatelet effect. How are we going to give this to people who have low platelets? Well, this is a highly selective type of BTK inhibitor to limit some of those off-target effects. And the mechanism of action here is believed to be just impaired B-cell activation, resulting in reduced pathogenic antibody production, which sort of interrupts that platelet phagocytosis and inhibiting some of those inflammatory pathways that contribute to ITP pathogenesis. In this LUNA-3 study, a total of 202 patients were randomized 2-to-1 to rilzabrutinib versus placebo. The median duration of ITP diagnosis was pretty long in both groups. It was 8 years in rilzabrutinib versus 6 years in placebo. Nearly half of patients in both groups had received 5 or more prior lines of therapy, including steroids, TPO-mimetics, IVIg, other immunosuppressives, Rituxan. I mean, this is a heavily pretreated group, much like we saw in that last trial. But because this trial was started after fostamatinib was made available, about 12% had actually had fostamatinib involved in their treatment as well. The way they did the study was that all patients who were on a prior therapy were continued on that therapy for the duration of the trial. Their primary endpoint was a durable plate response, which, suffice to say, meant platelets greater than or equal to 50 most of the time. And it had to be during the last 12 weeks of therapy without any additional rescue therapies being layered on. Looking at responses, about 64% of patients who received rilzabrutinib responded with a platelet count greater than 50, versus about 32% in the placebo arm. But remember that this study was designed such that people were continuing their therapies that they were already on. So we're not thinking that this is just a super powerful placebo that was causing responses. They were probably just responding to those underlying therapies. But rilzabrutinib doubled those responses. And more importantly, 23% in the rilzabrutinib arm had a sustained response versus 0 in the placebo arm. So this is something that is allowing people to get a more sustained remission. Among responders, the median time to response was about 15 days in the rilzabrutinib group. The need for rescue meds was also reduced by 52% in rilzabrutinib group. So we're looking at a lot of sort of really nice data for this rilzabrutinib drug.
And one other really important thing there is the patient-reported outcomes. We talked about how these patients can be fatigued. The physical fatigue was improved and sustained from weeks 13 through weeks 25 in the study, which really showed that we're having some potentially disease-modifying effect here. So I thought that was huge. And Dan, thanks for going through that. We've gone through a lot today. And Rona, can you just give a summary for the discussion that we had today?
Yeah, absolutely. The things that we covered today is what do we do in the situation where a patient is not able to sustain platelet responses after initial line of therapy, which includes either steroids or IVIg. And in these situations, we talked about the role that perhaps we can reach for things like rituximab or TPO-RAs as the next line of therapy. And in 2026, we also have the option of drugs like fostamatinib and the newest kid on the block, which is rilzabrutinib. Remember that splenectomy technically is always an option for patients. It's a much older therapy, but it is an effective therapy for patients. But as we discussed, comes with a whole host of potential complications. There's always a chance that it may not work, and we don't have a good way to determine who those individuals will be. And so I think it's fallen out of favor. But so many different ways that this can go. There's really no right or wrong answer. We don't have good information about how to sequence therapies. A lot of it is just expert opinion and guideline driven.
And I'll say one thing. If you have a patient that you tried steroids on, didn't work, and you're reaching for these second-line therapies very quickly, you should really think about a bone marrow biopsy to rule out other malignant causes of ITP and do a good lymph node exam, particularly in general when you see a patient with ITP. Make sure they don't have lymphoma. It's rare, but it's something you don't want to miss. So I think it's important when you're not responding to therapies, you should think to yourself, I need to probably look for something different. We'll talk about this in our cases in the next episode.
Guys, I think that wraps up another fantastic episode of the Fellow on Call. Until next time, we'll see you all later.